Welcome everybody to our TIF Talk Tuesday. I'm very excited to have two special guests today. We have Dr. Denny Tang. Welcome. Thank you for being here, Dr. Tang.
Hi,
and thank you. We also have one of his patients, Julie McCracken. Thank you so much, Julie, for being here today.
Oh, thank you for asking.
So my name is Andrea Millers, and I'm with Endogastric Solutions. And we have these TIF Talks every Tuesday to introduce a physician, guest, and also today we have a patient. At any time during this event, as you all know, it is live. So if you have any questions during the event, please feel free to ask your question, type it into the comments, and we will do our best to answer the questions. And you're welcome to ask Dr. Tang and or Julie any question that you'd like pertaining to obviously GERD, acid reflux, or the TIF procedure. So to give you a little bit of background of Dr. Tang, he is a board certified general and colorectal surgeon in Brookville, Pennsylvania. He earned his medical degree from the Temple University of Medicine in Philadelphia and completed a general surgery residency at Abington Memorial Hospital in Abington, Pennsylvania, and also a colon and rectal surgery residency in Grant Medical Center in Columbus, Ohio. So again, welcome Dr. Tang, and thank you for being here today.
My pleasure, thank you.
You're welcome. And Julie actually works at the hospital that Dr. Tang operates at. She also had her TIF about a year ago, and she's joining us to share her experience. So we're very excited, and we'll get to hear more about her journey with GERD and also her TIF procedure. But we're going to go ahead and start the whole program and discuss GERD and acid reflux and what could potential patients be feeling or suffering. What types of symptoms would they be feeling, Dr. Tang?
Well, as you know, GERD stands for gastroesophageal reflux disease, and I think really the key to remember there is it's a disease process. It's not just one specific thing, like say appendicitis is just one thing. As a disease process, it encompasses lots of symptoms. People are typically familiar with the classic reflux or heartburn symptoms, especially you have a late night pizza or wings or something, and you get that pain down in your lower chest. I mean, that's very typical, and that's what lots of people think of as GERD. But more and more so, I'm seeing folks who have what historically has been called silent reflux symptoms, and those are symptoms that don't necessarily show up as only the heartburn or the lower chest pain, but can actually be things like regurgitation or even a sour taste at the back of the mouth. Some people have come to see me and their only complaint is they got a lump in their throat, or they've been to see other doctors and they have a chronic cough that is not attributable to some type of lung process. I've actually seen folks where their allergist has sent them because they've done a whole allergy workup for postnasal drip, for instance. So more and more so, we're recognizing that GERD is really a disease process. It incorporates the classic symptoms, but also things that are considered atypical, or a new term nowadays is LPR. So that really stands for the silent reflux symptoms.
Okay, thank you. Julie, maybe you can share with us kind of the symptoms that you were feeling, obviously prior to the TIF procedure. How long were you suffering from GERD before you had the treatment?
I had GERD for a couple years. It was probably the last 6 months before my procedure that it was really bad. I'd have heartburn all the time. I couldn't sleep at night. I would try to sleep in the recliner, prop myself up in bed. And the one night that it was really bad is whenever I called Dr. Tang.
So how many years were you suffering before you called Dr. Tang? Was it a couple?
Probably about 2.
2 years.
Yeah.
And in that time period, what were you doing to kind of manage your GERD symptoms?
I try to watch what I eat, but working in a hospital, you grab and go, and I'd eat late. But then I would take over-the-counter meds, and at the end, before my procedure, I was up to 7 medicines a day, probably. about that.
Yeah. Dr. Tang, so what do you normally tell your patients to do? What are the types of lifestyle modifications or activities do you recommend patients to do while they're trying to manage GERD, even before, medical therapy and or the TIF procedure or any other, anti-reflux procedure?
Well, the lifestyle changes are something like what Julie just mentioned. Lots of us, we're in a rush. We eat on the go. Sometimes we eat in 10 minutes, and we just shove it all in, and we don't take the time to even enjoy the food. But that really helps to contribute to reflux by eating large meals all at once, by over distending the stomach. That actually causes more for reflux to occur. Just like Julie said, often we'll talk about trigger foods, and for lots of people, it's the classic caffeine, alcohol, spicy foods that everybody thinks of normally. But homemade spaghetti sauce, although it's great, it tastes good. It's got lots of onions in it, maybe garlic and tomatoes. I mean, those are all foods that potentially could cause reflux. So those are important things to try to identify trigger foods that can cause reflux. Other things that can contribute to reflux that you can help adjust from a lifestyle standpoint would be the timing of when you eat, just like Julie said. We want to try to eat and allow for at least 2 to 3 hours of being in an upright position to let gravity help pull things down and not lay down right away. We might not want to lay absolutely flat, especially if you have a hiatal hernia, and we might talk about that later. Prop your head up with some pillows or elevate the head of your bed. Those are easy things to try to do. One other thing that I usually tell folks is that certain habits that we have contribute to. One of them, for instance, is, as I mentioned earlier, is drinking alcohol. Even though it might taste good, everything has its place in moderation. And so, especially red wine, for instance, you have a nice evening out and you have a bunch of red wine. Don't you be surprised if maybe that night you have a lot of reflux. Or, the big thing for some folks is smoking. Tobacco, nicotine especially, is known to cause increased reflux. So those are some easy things. And then the one thing that some people don't think of is, and it's a little bit hard to broach this, I guess, gently with some folks, and I try to do this in a kind of a non-judgmental way, of course, is that very commonly lots of us carry extra weight, and extra weight is known, especially weight that's centrally around the abdomen, is known to increase reflux. So even losing 5, 10, 15 pounds as you watch what you eat can actually help to control your reflux symptoms.
Yeah, it's very good points. Very good points. All the good stuff you can't have.
In moderation, I guess.
I'm just kidding. So, what are, Dr. Tang, some options? What are some treatment options for GERD? Maybe you could talk a little bit about, the PPIs, the meprazoles, the, medical therapy. Are there other procedures out there, even outside of the TIF procedure? What are the treatment options for GERD and acid reflux?
Well, I, as a surgeon especially, I tell folks that, remember, before these medicines existed, before the late 90s, before Pepsid came around and kind of took the world by storm, and therefore then antacids, surgery existed. Something called a Nissen fundoplication has been around since the 50s, so it's predated medicine by 20, 30, 40, 50 years. And that's a surgery, for instance, where nowadays we do it laparoscopically. We physically manipulate the bottom of the esophagus, which of course is the tube that connects the mouth to the stomach, and then we manipulate the top of the stomach as well. And we do two things with that surgery, for instance. We know nowadays that the location of the lower esophagus and the upper stomach in the right body part is critical to proper functioning of the lower esophagus. And we take the upper part of the stomach and we wrap it around the lower part of the esophagus. I tell folks in the office it's almost like taking a scarf, for instance, and wrapping it around your neck, or one way to think of it might be as a turtleneck. And then in a Nissen fundoplication, for instance, the stomach is wrapped fully around the base of the esophagus in a full circle, and it actually augments the natural mechanisms of the lower esophagus to prevent reflux from going up into the esophagus. So that's one type of surgery, for instance. And there are actually others that are based off of medicine that can be done surgically as well. And then, of course, as you know, the TIF procedure is another way to do this type of fundoplication. That's the F in TIF. Call it when the bottom of the esophagus is wrapped by the stomach. There's a way to do it from the inside of the stomach as opposed from the outside of the stomach, which is doing it laparoscopically.
You can mute it. You can mute your microphone if you'd like. Or
it's just so live, right?
Yeah,
this
right.
Is live,
See?
everybody.
Yeah.
This is live.
This is what happens.
You're good. You're good. So, well, thank you for that explanation. So maybe, Julie, you can tell us a little bit about, so, you know, you said I think you said you were taking about 7 medications, up until you decided to call Dr. Tang. So were you taking PPIs and
Yes, I was taking like 2 Nexiums a day and Carafate 4 times a day, and once in a while I'd have to take a Tums.
Okay.
But you know, it was just pretty much my eating ways too, as well as rushing and everything.
Yeah. So working at the hospital and knowing that you have heartburn, and then you had been suffering for a while, and you said it got to a point where you couldn't take it anymore, and you called Dr. Tang. What type of research did you do to understand what your options were? Is it because you were at the hospital, you knew that there were options there, Dr. Tang was there, just to give other patients some idea of things that they can do to decide?
Yes. A little bit. I did a little bit of research. I generally just made an appointment with him to see what options that there were.
Okay. So did you know about TIF before or no?
No, I did not.
Okay, you knew that Dr. Tang did procedures for acid reflux and GERD.
Yes.
Okay.
Yes.
We have a lot of questions coming up, so I'm going to take this time to get a couple of questions answered. So thank you everybody on Facebook for asking questions. Let's go to the top here. We have a question from Muhammad. He's saying, hello all, is the TIF procedure durable? Can it last for years? I guess that'll be for you, Dr. Tang.
Hi, thanks for asking. I think so, yes. The TIF procedure has been found to be durable and can last for years, just as, for instance, as I mentioned earlier, you know, the progenitor was really the Nissen fundoplication. The only caveat I would give you, though, is that in the last several years, folks that do hiatal hernia surgery like myself and reflux surgery like myself, there's been a little bit of a shift in the way we think about hiatal hernia surgery as opposed to, say, a groin hernia surgery or a hernia of the belly button or something like that. In the office, and I'm not sure if you can see this, so in the office, here's what I tell folks. I take my hand, and as you can see, I have an opening in my hand, and what I say to them is, this hand represents the diaphragm muscle. That muscle separates what belongs in the belly here and what belongs in the chest up here. What I'll then show them is, I'll show them this hand, and I'll say, my index finger will represent the esophagus, which again is the tube that connects the mouth to the stomach, and then the rest of my hand will represent the stomach. And I'll say, listen, this is what the natural anatomy is supposed to be. And I don't know if you can see this, but most of my finger is through the opening of my hand, whereas the rest of my hand is below it. And I'll say, this opening is the hiatus. That's the opening through the diaphragm muscle. That's what allows the esophagus to pass from the chest into the abdomen. And as the hiatus, it is not snug against the esophagus because it can't be, because if the diaphragm is snug against the esophagus, it doesn't allow the esophagus to expand. And so then we can't swallow. Things get stuck. And so there's a natural gap, if you will, or weakness there that allows for the esophagus to expand. And so when I'm doing surgery, whether it's by TIF, whether it's by laparoscopic or any other method, when I fix the hiatal hernia, I leave a small gap there. Otherwise, patients will have problems swallowing afterwards. As we know from hernia surgeries, if you leave a gap it leaves a weakness. And so it is possible.
Oh, Dr. Tang, we're having a little bit of technical difficulties. Oh, you paused for just a bit. So you were talking about the gap, leaving the gap. Yeah.
Yes, the gap allows for a little bit of a weakness in that location. So with bearing down, for instance, it is possible for hiatal hernias to recur in the future. How fast does it recur? It really depends on how much bearing down somebody does to some degree. And so even though the TIF procedure is durable, just like a Nissen fundoplication is durable, for instance, it is known that there are some patients over time, especially if they're overstressing their body, that it could weaken. The nice thing about a TIF is you can always redo a TIF, which is great for me because as opposed to a Nissen, which also could be redone, there's no scar tissue left by a TIF procedure. And so I'm able to do a TIF procedure again on somebody with basically the same good results as I got the first time if it were to weaken in the future. So I guess that's kind of a long answer to say it is durable.
Yeah.
There's a little caveat to that.
No, that was actually perfect. And I like your representation and showing it with your hand. It's very easy to understand. And you did talk a little bit more about the hiatal hernia and how that also has an effect on the success of the TIF procedure if you have a hiatal hernia. So, Julie, it's my understanding you did not have a hiatal hernia, right? You actually had a straight TIF procedure.
Yes,
okay.
That's correct.
Okay. So did you know all of this, or you probably, when Dr. Tang probably taught you all of that when you had your...
He did.
Okay. Did he do that? Did he?
Yeah, I believe he did. I'm pretty sure.
Okay. Fantastic. Well, thank you for that. Let's answer a couple more questions, and then we'll continue talking a little bit more about the TIF procedure. We've got a question from Dawn. After the TIF, when can I discontinue my PPIs? Also, when can I resume working out? So those are all good questions.
I guess I'll take that, right? So yeah,
that's for you. Yeah, that's for you, Dr. Tang.
And these are questions that my patients ask me in the office as well, and I do tell them that there is a known effect of rebound acid production if somebody's been on a PPI or a acid reducer for some time. That's one of the sort of known side effects that occur when somebody's on a PPI for a long period of time. And so, especially with a TIF procedure, I like them to stay on antacids for at least a few weeks before they finally come off it. I'd like to have them sort of gradually come off it if they can. As to returning back to work, a straight TIF procedure, just like Julie had, is, as the I in TIF says, is incisionless. There's no cuts to heal. And so as long as they can work without overstressing themselves, they can go back to work whenever they feel comfortable. And I mean, we might ask Julie, how long was it before you went back to work? I don't remember.
I think it was very shortly after, like maybe 2 days or so.
Oh, wow.
Yeah.
Okay.
Yeah.
So, yeah.
I'm sorry. I was going to say, yeah, the biggest hurdle I tell folks with a TIF procedure of going back to work is, one, they can't lift more than 5 pounds for the first couple weeks. And for the first couple of weeks, I like them to be on a liquid diet. And so, Julie, went back to work in a couple of days. There are some people who maybe a liquid diet is not enough for them, and they just feel weak, they feel unenergetic. And so if that's the case, they should probably wait a little bit longer just to make sure that they're the ability to concentrate to be able to do the job safely and effectively.
Yeah. So let's talk about the TIF procedure. Can you kind of, I know you talked about it a little bit of how it works with the anatomy, but maybe talk a little bit more about what the TIF procedure is and how does it work functionally.
So, as I tell folks in the office, TIF stands for transoral, meaning it's via the mouth. Incisionless, as we said earlier, fundoplication. And fundoplication, once again, is a wrapping, if you will, of the upper part of the stomach around the base of the esophagus. And it's been found, again, by Nissen, in the 50s, so 50 plus years ago, that by doing this type of procedure, we are reconstructing and or augmenting the natural I guess, barriers, if you will, is one way to describe it, of the lower esophagus. And that is what prevents the reflux from occurring from the acid contents, the stomach contents, which are primarily acid or even food stuff, from entering into the esophagus. And so transoral, of course, is just like if somebody's had an endoscopy or a scope of the stomach. It's a scope that's inserted through the mouth after they're asleep, so they don't feel anything, they don't remember anything. And so with the same scope and the TIF device, I'm able to, from the inside of the stomach, cause a wrapping of the stomach to occur without any surgery per se. And so it does recreate, I tell folks, about a 3/4 circle wrap. So, a Nissen, as I say, is a full circle. So a TIF causes about a 3/4 circle wrap, and it still seems to provide the same exact relief to reflux as a Nissen does. And that's what really was so exciting for me when I first heard about TIF years ago. The nice thing also about a TIF in some ways is it does only cause a 3/4 circle wrap. So decades ago, before TIF really, I think, was even FDA approved, I had a patient who had reflux at the time I recommended a Nissen, and I discussed with him that it's a full circle wrap, and as a full circle wrap, although most people should be able to burp afterwards, nothing else comes up. Reflux doesn't come up, but also vomiting doesn't come up. And this was an unusual story. This patient had a little bit of an irregular heart rhythm, and the way he stopped it on his own was he would gag himself and throw up, and as soon as he threw up, it would stop.
Wow.
Yeah, it was kind of different. And I said, wow, that sounded like you. I said, wow, okay. And anyway, and he was very concerned that with a Nissen, he wouldn't be able to control his own arrhythmia. And so he actually declined having a Nissen for that reason alone. I wish I could remember who it was. I would call him today and say, hey, listen, we got something else for you that will work and control your reflux and still let you throw up. But,
wow, that's an interesting story. Golly. So Julie, tell us a little bit about your decision-making process when you were trying to decide. I'm assuming, Dr. Tang, you talked to her about the different options, Nissen, potentially TIF. How did you, Julie, make your decision as to what was the right procedure? Oh, you're on mute.
There we go. Seeing that I didn't need the Nissen and the TIF didn't have any incisions, like Dr. Tang said, that seemed to be the easiest and I've heard the most helpful surgery to do.
Oh, fantastic.
Which it is.
Yeah, wonderful. So let's talk a little bit about recovery and what do you, Dr. Tang, normally, or actually before we do that, a big question that comes up all the time from patients is the workup. What types of tests do I need to take? What are the different, what do I need to do in order to work myself up to have the TIF procedure? Are they getting an EGD? Are they getting a Bravo? Are they getting a manometry? What are the different types of workup or diagnostic tests that you require your patients to have?
Okay. Well, actually, even before we talk about diagnostic tests, I think one of the most important things is what we're doing right now is we have a discussion about what the symptoms are, what they've tried before in the past, what has worked, what has not worked, what their expectations are, because that's a very big one as well, I think. And assuming that they come in and it sounds like they have some type of reflux, whether it's that classic reflux of heartburn or it's the more silent reflux, you're right. The first thing I usually start with, almost always, is an endoscopy, which is a scope of the stomach. I want to take a direct look at the lining. I want to see if there's any inflammation. I want to see if there's any ulceration. On the inside of the stomach, I can tell, for the most part, if somebody has a hiatal hernia as well. And that's very important because maybe we'll talk about this a little bit later. There are certain criteria about a hiatal hernia as regards to having a TIF versus having something more than just a TIF. So I want to look to see how big somebody's hiatal hernia is, if they have one or not. I want to take some biopsies. I want to try to have tissue proof that there's inflammation. I'm looking for something called Barrett's, which is a I tell folks an indirect, direct proof that somebody has reflux, even if they don't have any obvious symptoms, because Barrett's is what we call the change in the tissue lining of the esophagus. I tell every patient that the stomach is designed to withstand acid, but as acid moves into the esophagus, it encounters tissue that's not designed to withstand acid, and so it actually causes a change in the tissue type called Barrett's. And Barrett's is very important because not only does it prove to me somebody has a reflux, no matter what else they say, but we also know that Barrett's is an important factor to possibly developing precancer or even cancer of the esophagus. So I'm looking for that as well. Sometimes folks come to see me and they just simply complain of belly pain, and so I'm also doing biopsies to make sure that they don't have some type of infection that's just not reflux, that's just something else. So I don't want to assume that every patient who comes in to see me and describes something has obvious reflux. I don't want to look at everything as a nail if my only tool's a hammer. So
Right.
I really want to examine that. So that's my first thing. And then I tell folks that, just like you mentioned, there's a test called the Bravo test, and it's a little sensor that gets clipped to the inside lining of the esophagus, and it can actually measure for me how much acid is actually coming up into somebody's esophagus. And the nice thing about this little test is not only that, but there are some buttons that the patient can push on the device that can help to give me a sense of what is the correlation between their symptoms and acid reflux. And I tell these folks, you know what, if you wanted to do one-stop shopping, I could do it at the same time that we do your endoscopy, because the only way to get that little sensor in is actually to do an endoscopy. So if they seem to be somebody who maybe we're going to be trying to do the full gamut, I might try to do that all at once. And so that's the first step. Have a good discussion with them, try to understand what's been going on and where they're headed, what they're looking for, and then that's where I start, is with an endoscopy. And then, as you said, there's some other tests that can be done afterwards, and that's more for the workup, to deciding, are they a candidate for surgery? Is a reflux surgery, an anti-reflux surgery, which TIF is part of, is that the right answer for them? Or do they actually have something else? There are actually other disease processes that affect the esophagus that are not treated and actually worsened by doing anti-reflux surgery. And so I want to make sure that those are not a component of what their symptoms are.
Yeah, makes sense. Wonderful. So we do have a question, and I think you were talking about this, and maybe you can go into it a little more in depth about the hiatal hernia. So the question is, if you have a hiatal hernia of only, she's saying 2 centimeters, she corrected herself, that will be fixed by the TIF, Dr. Wells performing the TIF or as a separate procedure? Oh, that's a good question. So they're asking, do you fix the hiatal hernia separately, or do you do it while you're doing both?
That is a very good question. And so the TIF device is actually cleared by the FDA to handle a 2 centimeter or smaller hiatal hernia. The way it's done, that's not an issue. Now, when we talk about hiatal hernias, we have to remember that it's a 3-dimensional structure. So 2 centimeters up and down is a little bit different than 2 centimeters across. And so that's another thing that I can tell based off of an endoscopy, for instance. We're talking more about 2 centimeters up and down. That's probably okay. That probably will be handled by TIF. If you do 2 centimeters across, that's a different story now. Now we have a hiatus, the opening of the diaphragm, that's too broad. And as I kind of mentioned briefly earlier, the location of the esophagus and stomach is probably just as important as the wrapping of the stomach. And so if I wrap the stomach with a fundoplication, but it's sitting in a horizontally 2 centimeter hiatal hernia, that's actually not going to work. So in that situation, I do recommend a laparoscopic hiatal hernia repair. It's the first part of the Nissen, where with a few Band-Aid incisions, we're able to laparoscopically maneuver, here's my picture again, right? Maneuver the esophagus and stomach into the right position. That will expose how big this opening is across, and with some sutures, we're able to narrow that down. And then at that point, we can either opt to continue and finish a Nissen fundoplication, which is the 360-degree wrap of the stomach, or do a TIF. And more patients nowadays, if able to, are telling me, you know what, just fix the hiatal hernia, I'll take the TIF. And the thing I didn't mention earlier is, there are some risk profiles to any surgery that is performed. One of the biggest negatives of Nissen is something called gas bloat syndrome. It's when somebody's stomach doesn't empty properly, and it's usually related to too much dissection and or too tight of a wrap of the stomach around the esophagus. It can be very uncomfortable. It can also be permanent, unfortunately. I tell folks that they might have a small sip in the water in the morning and be bloated all day without eating or drinking anything else. And unfortunately, if I undo the Nissen or loosen it, that's no guarantee that gas bloat syndrome will go away. Luckily, it doesn't happen that often, but it does happen. But the best thing about the TIF that I tell patients is there's no documented reports ever that gas bloat occurs with a TIF. And that's probably because we're on the inside of the stomach. We don't even see those nerves. We're not even messing with those nerves. And so lots of folks will tell me, listen, fix my hiatal hernia if you have to, laparoscopically, but then give me a TIF. And I've been very happy with how those patients have come out. They, side by side, you probably wouldn't be able to tell that somebody had a TIF or a Nissen. They do that well. And so that's the nice thing about doing it. So short answer is yes, hiatal hernia should get fixed at the same time as a TIF. Like I said, if you do a TIF without a hiatal hernia repair, you're really not helping the patient. You're just simply prolonging their suffering with reflux.
Right. That was a really good explanation. Thank you so much, Dr. Tang. Now we can kind of talk a little bit about recovery, maybe talk about the day of, what to expect, and then maybe, Julie, you can tell us your experience, but what can a patient expect? How long are they in the hospital? Are they there overnight? Are they there for longer? Is it different if they have a hiatal hernia repair versus just a straight TIF? And then what does the recovery look like? Diet progression, and I think you spoke a little bit more about, earlier about when to go back to work, but talk to us a little bit about that.
So I'll tell you my own personal view, of course. Now, you can ask 10 surgeons, right, and get 10 different opinions probably. So there is probably a little bit of variability in how folks handle this. But as Julie knows, when I do a TIF procedure, or if I do a hiatal hernia repair with TIF procedure, those patients go home the same day. I had one patient who stayed overnight, and that's always open to any patient, of course. If for some reason they don't feel comfortable or they have pain or nausea or something, then we will keep them overnight to make sure that they're comfortable. But by and large, it's an outpatient procedure. Early on, I would send folks home with a small prescription of some pain pills. And as time has gone on, I've asked every patient, how was your pain? Did you take your pain pills? And more of them say, no. I just took Tylenol, or I just took Advil. And I'll say, okay, fine. So nowadays, I hardly give them any prescription pain pills at all. I tell them Tylenol and Advil on a rotating basis, maybe some ice, and they're usually good. Most folks, if they've not had an incision, I tell folks kind of feel like they got kicked in the gut a little bit. It's more of a sore, achy pain than anything else. It's not really a sharp pain. The sharp pain is usually if I do a hiatal hernia repair at the same time, and it's usually related to the skin being cut. But usually afterwards, it's really, in my opinion, more muscle aching pain than anything else, which is why they really don't need a prescription pain pill. So, a TIF procedure by itself, probably 30 to 45 minutes in general for the actual procedure. And then they're in the recovery area for maybe a couple hours, something like that. We want to make sure that they feel comfortable enough. We want to make sure that they're not nauseated. We want to make sure that they can tolerate drinking some liquids, because that's what they're going to have to do when they go home. And if so, we'll let them go home the same day. And so recovery in that sense, or hospitalization in that sense, is very short. And especially with COVID, I actually had one patient who was kind of on the fence of a TIF versus a Nissen. And when they found out that they go home the same day, they said, okay, I'll take the TIF.
Nice.
Because they didn't want to be in the hospital. I'm like, oh, okay. I never thought of it that way, but okay. That's a good reason to have TIF. So,
wow.
Yes, the same day. But then,
so,
I do tell folks that, this procedure, just like any procedure, is a partnership. I do my job more so in the operating room. The patient has to do their job afterwards. I can't be there every minute afterwards. And so when we try to make sure that they understand that there's a certain recovery that they should expect. And like we talked about earlier, they are on a liquid diet for about 2 weeks. And so we kind of go over what kind of foods, well, actually drink, I guess, or liquids that they're allowed, and when they should feel comfortable to increasing what they're drinking and or eating. And we give them the brochure that kind of outlines what are they going to do the second week, what are they going to do the third week, the fourth week. The brochure is very nice. I mean, it has some samples of groceries that they might buy to be ready. And we start that process way before in the office. When we're first even thinking about TIF, I'll start to give them that information so that they can think about it and to be prepared. So that's the diet part of it. For the TIF, as you probably know, it's not done with sutures, which is kind of an interesting thing. With a Nissen, I do it with sutures, and I tell folks, it's a fairly hefty suture. It's definitely thicker than a fishing line, for instance. The TIF procedure is done with fasteners, which are little plastic H-shaped devices, if you will. It reminds me of the sales tag on clothing, and I say it really is just about that thin. And so I caution patients that it takes tissue that's been brought together probably about 10 to 14 days before it really starts to stick together. And so for the first couple of weeks, the only thing holding that fundoplication together are really those fasteners. And so that's really why the liquid diet. That's really why they really shouldn't lift more than 5 pounds, in my opinion, for the first couple of weeks. That's also why I send them home with a little nausea pill to place underneath their tongue for the first 2 weeks. I really don't want them to even feel like retching during the first 2 weeks. And just take it easy. Like, as we said earlier, if you're a superwoman like Julie, you can go back to work. Okay, fine, as long as you don't have to lift, as long as you have the energy, because you're only on a liquid diet, that's fine by me. But no lifting significantly until 3rd, 4th, 5th week, something like that. And by that time, they're on more of a soft and formed food type of diet.
Okay. Yeah. Wow. Wonderful. Julie, tell us a little bit about your experience. How was the day of? We'll pretend Dr. Tang's not listening.
Oh yeah. Can you mute him right now? No.
I'm just kidding. No. So tell us a little bit about your experience being in the hospital, having your procedure, and then how everybody asks. All patients always wonder, how was the diet? Was it as hard as it sounds? 2 weeks of liquid. Wow, that's going to be crazy. And then how did you progress? Tell us a little bit about your story.
Oh, sure. The day of my procedure, it was very smooth. No discomfort, anything like that. Following that, I only had a little bit of discomfort, but nothing major. The worst part about the whole TIF is the diet.
A lot of people
if
say
I never see a mashed potato again, I will be fine.
So, did you adhere to the 2-week diet,
I
liquid
did.
diet? Okay. And were there certain, a lot of patients always ask for recommendations. Was there anything in particular that you loved, aside from the mashed potatoes that you could drink? Did you drink a lot of protein drinks or?
I did. Some shakes. Yes. Okay. I did a lot of soft fish. No fried or anything like that. I did get a lot of rice, cauliflower, and broccoli. I would add a little bit of cheese to it just to make it taste a little bit better for me anyway, But yeah. And I have had mashed potatoes. I will say that, but not nearly as much as I used to like.
So how was the progression for you with the diet? The first 2 weeks you're on liquid and then you can slowly progress. Were you nervous about it? I see on some of the group chats that they're nervous about taking their first, bite of food that's going to be more than just the liquid. Was that a concern for you, or was it pretty easy?
For me, a person that eats on the go, like Dr. Tang said, you're like shoving food in 10 minutes, and you just have to think to yourself, you have to slow down and chew and, not take big bites and things like that. So once I programmed myself to do that, it wasn't bad at all.
Oh, good, good. And then you went straight, like you said, 2 days right after you had the procedure.
I think, yeah.
Yeah. Did you have any, were there any issues? Was it pretty easy sailing? Did you feel like you had just had surgery, if you will, or how?
Not bad at all, no. The toughest thing was, I work in the lab with a bunch of girls that like me like to eat, so that was the toughest part. They're all eating, and I'm like, okay, I'm gonna go for a walk.
So here's the final part of it all: living GERD free, and kind of how are you today? So you've had the procedure you had it about a year ago. So
Yeah.
so are you taking PPIs anymore? How are you feeling? Do you still get acid reflux and GERD, today? Tell us a little bit about that.
It's been, I think, about 16 months since my TIF, and I might have taken maybe one Tums because I've eaten something, being somewhere, and I thought, just in case this bothers me, I'm just gonna, but that's the only thing is one time I have not taken any over-the-counter or prescription GERD medicine since then, and I feel 1,000 times better. It was the best choice I ever made.
Yay. Wonderful. Do you hear that pretty often, Dr. Tang, from your patients that had the TIF procedure?
I do, and especially early on when I first started doing the TIF procedure, which is just about 2 years ago, that was one of my measuring sticks. I wanted to know how my patients felt compared to my own experience of how my Nissen patients felt. And when folks would come in and say things like this to me, that's really what sold me. That not only did this procedure seem to follow good science based off of what I knew with, say, the Nissen. The fact that folks said, yeah, I feel the same, I feel great, I don't take medicine. Like I said, that's really what sold me, and that's what I tell patients all the time. I'm in the business to try to make people feel better, and if I do a procedure that doesn't make them feel better, well, I'm gonna stop doing that procedure. So, right. I have not found that to be the case with TIF. TIF really, I think, has made a significant change and improvement in possibilities for anti-reflux surgery. And like I said, patients seem to do great. And they come in here, and much like Julie, they tell me that things are great. Now, I do caution people, just like we said earlier, with expectations. And I do say, listen, it's not impossible to have reflux after a TIF. It's not impossible to have reflux after a Nissen. Everybody has some degree of reflux.
Right.
Like I say, if you're going to have a whole bucket of wings, maybe you're going to have reflux. So if you're going to do that and you take some Tums, well, that's not the end of the world. That's actually normal. That's to be expected. I've been very pleased with how patients have done with the TIF.
Wonderful. We do have a few other questions that I want to try to get to. We have someone asking, if I had a Nissen previously and have recently started to experience GERD symptoms again, can I have a TIF?
I would say yes, depending on that workup, as we talked about earlier. But like I said, the TIF is great in the sense that I can redo somebody's previous surgery, whether it was a Nissen or even if they had a TIF that weakened over time, and it's almost as if I'm doing it for the very first time. There's no scar tissue like when I'm doing a redo Nissen, and there's usually no impediment at all to me doing a TIF. As long as they meet the same criteria as any other patient, hiatal hernia is the right size or smaller, and there's no other anatomic differences, then that's actually my preference nowadays. Is I actually try to steer patients to get a TIF if they had a previous Nissen and they have recurrent symptoms, and it works great.
Wonderful. Okay, one other question. In the long term, what physical activity restrictions do you tell your patients to be careful of? I think you already talked about that. And then also, can you have a LINX procedure after a failed TIF as another option?
Yes, I guess is the short answer to that. So LINX, we didn't really talk about that. Is a new, relatively, procedure as well. The difference with LINX is TIF and Nissen both use natural tissue. Your own stomach tissue is used to increase the strength of the lower esophagus. In a lynx, a ring of magnetic beads is implanted and encircles the esophagus. I know folks who do it. I've known patients who have done well from it. I've known patients who have had the reported side effects of it. As you mentioned earlier today, I'm also a colorectal surgeon, and this is kind of a long aside, but a similar type of thought process was developed for folks who have, for instance, rectal prolapse, where you simply encircle the anus. Not many people, hardly at all, do that procedure nowadays. So that says something to me. That used to be around, and that's still historically taught. It's in the textbooks, but rarely do we encircle the anus for rectal prolapse. What will happen with the lynx? I don't know. I'm not a mind reader or a fortune teller. There are some people who do very well from it, but like I said, the difference is you have to have a material implanted around the esophagus. There is a known side effect rate of problems swallowing afterwards. There's a known incidence of having to come in to have stretching of the esophagus post-operatively a year, 2 years, maybe even more down the road. There are some potential complications that can occur from implantation of a foreign material around the esophagus. For the folks who it works great. But for the folks who it doesn't work, it usually requires surgery to then remove the lynx device. And so, we take it up then. But yeah, a TIF does not burn any bridges. You can actually do a Nissen after a TIF if you really, really wanted to. You could do a lynx if you wanted to. You could do any other type of anti-reflux surgery after a TIF. So the TIF does not burn any other bridges.
Wonderful. Yeah, thank you. We appreciate that. Well, that's all the questions we have today, and we're getting close to wrapping up. I do want to ask Julie, is there anything that you would recommend, our viewers that are watching, or anyone that comes back to watch this, or that is suffering from GERD or acid reflux? Do you have any recommendations or anything that you would tell them to help them with what they're suffering from?
I would just tell them, if they are thinking about doing anything, they should go for the TIF if they're able to, because it is the least invasive. And like I said, if you can get past the diet part, you're smooth sailing,
Well, you got past it.
Yeah, I did.
You got past it, and you're GERD free now, so
yes, thanks to Dr. Tang, I am.
Wonderful. And Dr. Tang, any last words from you, or anything that you would want to let our viewers know before we head out for the evening?
I guess the only thing I would tell folks is that, listen, you don't have to have reflux. And especially if you've had reflux for a long period of time, if you've never had a scope, personally, I think you should at least have a scope just to make sure there's no other issues going on. Just because you come in to see me, for instance, doesn't mean you have to have surgery. It's kind of like stepping into a car dealership. Just because you talk to the guy, it doesn't mean you're buying that car, right? Even though he might think so.
That's a good analogy. I like it. Wonderful. Yeah, so if you guys are obviously in the Brookville, Pennsylvania area, obviously Dr. Tang is there. But if you are watching and you are looking for a physician that does the TIF procedure or specialist, you can visit gerdhelp.com or even our Facebook page. We also have a YouTube channel. But on gerdhelp.com, there is a physician finder. So if you're anywhere in the world and you're looking for a TIF specialist, you can just put in your state or your zip code, and you'll be able to find physicians in your area that do the TIF procedure. But again, if you're in Brookville, Dr. Tang is there. So again, thank you so much, Julie and Dr. Tang, for being here tonight and doing this TIF Talk with us. I know the viewers that are watching appreciate to hear from you, Dr. Tang, and listen to your expertise, and then also from you, Julie, on your journey through GERD and the TIF procedure. So thank you for being here again, and everybody watching, please stay safe. And our next TIF Talk, actually next week, will not be on Tuesday. It will be on Thursday. So come join us next Thursday for our TIF Talk, and please stay safe and have a good evening. Thank you very much again.